slide, please.
So welcome everybody to our Grand Rounds. And this is a very special Grand Rounds because we're going to have one of our faculty members. And as we know, we got terrific people, leaders in their field. So as we all know, we're going to have Dr. Quinn. He's going to be doing his Grand Rounds presentation today. And very briefly, in terms of his CV, I always like to joke that from the academic point of view, he's got the perfect pedigree, Princeton, Harvard, etc. But that doesn't mean, that's not really why he's done so great. He's a very hardworking individual, has the right approach, creative, etc. He's going to talk about research today. And of course, as we know, his major area of interest is TMS. And he's a true leader in the country, not only in terms of research, but how can we get more TMS to our patients. As we all know, he is the vice chair for adult clinical services. He's done a terrific job, as those of us who deliver care in the adult services know. So it is really my honor and pleasure to introduce Dr. Davin Quinn. Davin.
Thank you so much, Dr. Toen. It's an honor to be in this department and to be able to speak to you all today. I'm going to go ahead and share my slides. Can you all see them?
Yeah.
Okay, super. As Dr. Toen said, I'm going to be speaking on transcranial magnetic stimulation today. It's a passion of mine right now. I'm super excited about it as a clinical treatment and option to offer our patients, as well as a research device and tool. I think we're at a really sort of an inflection point in terms of our understanding of the brain and psychiatric disorders as they manifest in the brain, and how we can sort of tap into the pathophysiology that seems to be driving these disorders and modulate them and ameliorate them with non-invasive brain stimulation, which is my area of research. So just to tell you my disclosures, I'm coordinating PI on 2 DoD-funded multi-center trials of brain stimulation and traumatic brain injury. I'm also co-PI with Chris Abbott on the project that I'll be sharing with you today, which is a pilot study of TMS, targeted TMS for late life depression. So the goals of the lecture today, first of all, I'd like to briefly review the principles of repetitive transcranial magnetic stimulation for major depression. The middle of my talk will be about the strategies that we use to optimize TMS for depression. There are several maneuvers and techniques that can be used that help to boost the efficacy while maintaining the safety of this approach. And these include prediction, parameters, precision targeting, and personalization. And the alliteration there is intentional. And then finally, I'll tell you about some of the early results that we're getting out of our pilot study, individualized targeting of neuromodulation for late life depression, and why I'm really excited about them and where I think this is going to go for next steps. So I'd like to start off with a case. This is a case that is very typical for the type of patient that we see on our clinical TMS service. And I welcome you to please contact me if you have referrals from your clinics that you'd like to see if they are a candidate for TMS or not. So this is a 60-year-old female with chronic major depressive disorder since early adulthood. She has a history of physical abuse in childhood and a hospitalization in early adulthood after a suicide attempt. She was recently diagnosed with comorbid PTSD and manifests chronic symptoms of low mood, anhedonia, guilt and low self-esteem, low motivation, difficulty focusing, and low energy. So almost pan-positive SIGI caps. And she's tried a number of medications, including fluoxetine, citalopram, venlafaxine, bupropion, buspirone, vortioxetine, mirtazapine, trazodone, aripiprazole, augmentation, and lithium, and had only partial benefit or side effects with medications and psychotherapy. So this, as I said, is a very common picture for us to see on our service. Someone who's been suffering for depression for decades, in fact, has been depressed longer than they've not been depressed in their life. And that was one of the things that I was alluding to with the title of my talk, Melancholy and the Infinite Sadness, which is, of course, taken from the iconic Smashing Pumpkins album from the early 2000s. But it alludes to the fact that these patients who come to see us have been suffering with depression for a long, long time, relentless chronic depression. So let me just quickly go into the principles of TMS for you all who are not familiar with it. TMS is a form of non-invasive neuromodulation that has therapeutic benefit. It involves the repeated induction of electric currents in the brain via an externally applied, rapidly changing magnetic field for the purposes of improving a symptom or disorder. And the magnetic field has to be changing. It's not like you can take a magnet, like a magnetic rock or a stone or a kitchen magnet and hold it against your head and induce brain changes. The magnetic field has to be changing in its strength in order to induce a current. And that's due to Faraday's law, which basically states that an electric current changing over time induces a magnetic field around it. That's how we use a stimulator to create a magnetic field. And then the magnetic field changing over time induces an electric current in anything that can conduct a current that falls within the field. And so as you can sort of see, these are two examples of TMS coils. One is a circular coil and one is two circular coils put together to form a figure of 8. And the magnetic field shapes created by these coils summate, in the case of the figure of 8, to create a peak. And it's this peak of magnetic field flux that allows us to be very focal in the stimulation that we deliver to the brain. So TMS has a number of effects on the brain. First of all, it increases or decreases cortical excitability. Cortical excitability is the number or strength of the neurons in terms of how they fire in relation to a stimulus, in relation to a TMS pulse. And so you sort of see how here on the left, this is an example of a muscle twitch that is caused by a motor evoked potential from TMS. And then when you deliver 1 Hertz TMS, you actually cause the muscle twitch to diminish. So cortical excitability goes down. The number of neurons that fire that lead to muscle twitching goes down. Whereas if you give excitatory TMS, 10 Hertz TMS, the muscle twitch gets bigger. And so we can modulate how many neurons fire by actually delivering TMS pulses to change the behavior of the neurons. So that's cortical excitability. Cerebral blood flow also can change. And what you see here is a graph of the concentration of oxygenated hemoglobin. And what you see is the baseline, which is blue. And then what happens when you deliver TMS on the side of the brain where the TMS is being delivered, the oxygenation content goes up. Whereas on the side that is contralateral to the TMS stimulation, which is far away from it, it remains at baseline. So the stimulation themselves can actually induce increased cerebral blood flow and increased cerebral oxygenation. TMS can also alter regional metabolism and functional connectivity. So the top right picture, what you see is metabolic activity as registered with positron emissions tomography. And on the side that was receiving inhibitory TMS, you now see it's more green, which means that metabolic activity has gone down. Whereas on the side that did not receive TMS, it's remained in sort of the yellow-red area, which corresponds to the normal metabolic activity. So this is how we know that TMS actually can alter the metabolism of the brain. And then similar studies have shown that connectivity between brain areas, or how tightly linked does the does the cerebral blood flow of those brain areas vary with each other. So if they're tightly linked, then you have them varying at this in concert like this, that's considered high connectivity. Whereas if they are not varying in some relation to each other, they're considered to have low connectivity. So what happens when you deliver TMS down here in the lower left, what you see in the second box is that there's a particular area that's connected to the area being stimulated, and that connectivity of that area with the stimulation zone has increased, as you see by sort of the red bar here. So TMS can alter regional metabolism, but it can also cause connectivity to connected regions to be modulated as well. So these are all really important for how we think TMS exerts its therapeutic effects. What's great about TMS is that it's you can do different things with it, depending on how you deliver TMS pulses to the brain. So if you deliver a pulse 1 time-second at 1 hertz, it tends to have an inhibitory effect on the brain area underneath that's receiving the pulse. And like I said, we know this because the motor evoked potential will diminish after you deliver 1 hertz TMS to the motor cortex. If you deliver 10 hertz TMS 10 times a second, it's considered excitatory, and you'll get an increase in the motor evoked potential. We also have different patterns in which triplet pulses are delivered. That's called theta burst. And if you do theta burst in an intermittent fashion, that can generate increased MEPs, so it's considered excitatory. But if you do theta burst in a continuous fashion without any breaks in between, it actually has an inhibitory effect. So we use TMS in these different ways and with these different pulse patterns to create different effects in the brain. And it's very, very useful. It's been very useful to be able to study what happens when you inhibit a part of the brain versus when you excite it. And you can sort of actually correlate changes with the brain with changes in behavior using this paradigm. And then TMS is delivered to specific places in the brain in order to have specific therapeutic effects. So for depression, the spot where it's delivered is called the dorsolateral prefrontal cortex. It's right here, sort of if you put your hand kind of at the corner of your forehead, sort of near the hairline, just above the eye. This is approximately where your dorsolateral prefrontal cortex is on either side. And what we've learned over many studies is that if you deliver excitatory to the left DLPFC, that improves depression. And that was done originally by Mark George and Pasquale Leone in the 1990s. However, if you do inhibitory over the right DLPFC, over the right hemisphere, that also seems to improve depression. And that was sort of a quite interesting finding that early on in the history of TMS gained traction because Pasquale Leone study where he did excitatory to both sides. He did excitatory to the left DLPFC and excitatory to the right DLPFC. And as you can sort of see in this graph from his study in 1998, the depression score went way down when he delivered excitatory to the left, but it did not change at all. And in fact, in some people even went up if he did excitatory to the right. And that has led to this very dominant, very sort of common convention in TMS for depression, which is to say that we want to excite the left hemisphere, but we want to inhibit the right. And that gained a lot of support from what we know both theoretically, empirically, as well as conventionally about how the left and the right hemispheres are different in humans. So we're thinking that the left hemisphere is the more manic, scientific, verbal side of the brain, whereas the right hemisphere is the more melancholic, brooding, anxious, artistic side of the brain. And if you can get more of the manic scientist and less of the melancholic artist going on, then we can you can alleviate depression in that way. So very, very sort of hand wavy and very kind of metaphorical, but that is how TMS is predominantly delivered around the world today for depression. according to that paradigm, excitatory on the left and inhibitory on the right. So how effective is TMS? This is what I tell our patients who come to us on the clinical service. I tell them that you have about a 60% chance, and that's what this study shows, is that overall in about 307 patients in clinic, when they receive TMS, you have about a 60% chance of responding. That means responding means that at least half of your depression, 50% of your depressive symptoms go away. And you have about a 33% or 1/3 chance of your depression going away completely, so that you are in remission, so that you're no longer considered to have clinical depression. And these are actually really, really good numbers when you're talking about the kind of treatment-resistant patients that, like what I described in the case earlier. So how does this compare to medications? Well, this is STAR-D. This is one of the most complete studies of stepped treatment of depression that we have. You go through 4 levels in STAR-D. You get 4 medication trials. And when you start out at the first trial with citalopram, you have about a 33% chance of your depression remitting. And with each successive trial of medication, you have a diminishing chance of your depression being alleviated. So that by the time you reach level 4, down here, you're trying an MAOI or venlafaxine plus mirtazapine, you have maybe a 15% chance. So this is after 4 drug trials. All of our patients who come to our TMS service have had at least 4 drug trials, and more likely have had 15 to 20 drug trials. And even so, in that case, we see TMS having a 40%, 33 to 40% chance of remitting your depression. So this is, 2 to 3 times more powerful than trying another antidepressant if you're at this stage. And that's what I tell patients, and usually they are then willing to move forward. I'd like just to have a quick shout out to our TMS clinical service, to Kathy, Angela, Josh, Monique, Michelle, and Ashley, and Araceli, who's now pictured here. They are the reason why we can do TMS here at UNM. They are operating way beyond the top of their licensees. They deliver the treatments, they work with the patients, they elicit their symptoms, elicit side effects. They are just an outstanding, stellar bunch. I feel so incredibly lucky to get to work with them every day. And my part on the team is I'll do the initial evaluation of the patient, make sure that they can receive TMS safely and that they have the appropriate indications, that we figure out where the target is that we should put the coil for them. We figure out what is their dose that they're supposed to receive. And then depending on how they're doing with the treatments, we make modifications based on their side effects and their symptoms. So we work together as a team, and it's one of the most satisfying things that I get to do here at UNM. This is our service. This is we started our service in 2017. These are all the patients who we've treated, represented in order from left to right when they receive treatment. And as you can sort of see at the beginning here on this graph, what you see on the y-axis is the percent change in their depression score. So here at 0.5, that's 50%. So if you're above this line, that means that you are responding. You're getting more than 50% of your symptoms going away. If you hit 1, that's 100%. So that means all your depression went away. So you can sort of see that at the beginning here on the left, we did not get many patients above that 50% line. So that was the first 6 months. We were kind of working out the kinks. We were learning the techniques. We were learning who is an appropriate patient for our TMS service, who is not. And then once we hit 2018, we started having more success with achieving getting people to respond to the treatment. We were still having a lot of people though who had no benefit, and even some people who got worse down here where their symptoms increased. And as over time since 2018 till now, what we've been doing is altering and modifying the parameters and the way that we deliver treatment so that we're actually able to now here in 2021, over here on the right side, we don't have anyone who's getting worse. And in fact, it seems like we have a majority of people who are responding. Out of the last 30, there's about 17 or 18 who have responded here. So we're hitting those benchmarks that were indicated in the naturalistic study that I showed you earlier, where we have about 60% response and 33% remission. So I'm very happy about this. There's an overall trend of increasing efficacy over the last 4 years, and due very much to the efforts of our team. Oops, sorry. One interesting thing that's come up, and this is where clinical care informs our research. So this is why I'm really sort of excited about our TMS service and it being kind of at the forefront of how TMS is delivered, is we have the choice of stimulating on the left, on the right, or both. And we usually start people out on the left. So you can sort of see in this pie graph, the blue is who starts with the left, the red is who starts with the right, and the green is who starts with both. So very few times do we start someone with both sides being stimulated. It's like starting two drugs at the same time. It's quite hard to sort of tell, what is happening as a result of stimulation on which side. So we usually start with the left, but what we see is that the side that people finish their treatments on can change significantly. And so what we see is that more people end up getting right side stimulation than we originally started, such that there's only about half who stay on the left, and the other half are getting some form of right side treatment, either with or without the left side. And this is what, when I started seeing this is what really kind of woke me up to the idea that it's not one size fits all in TMS. We can't just bring everyone in, stimulate in the left DLPFC with excitatory stimulation and expect them all to get better. We're not seeing that. And in fact, there's some people who respond way better to right side stimulation. And it's not necessarily obvious who that is before treatment. So let me just sort of point out that this is what a recent meta-analysis shows. Again, kind of what I said, which is that high frequency to the left and low frequency to the right, or the bilateral combination of those two, are what are considered standard TMS. And you can sort of see the effect size expressed there. Lots of studies have shown this, and so you have very sort of narrow error bars on that. And what was not effective, or what's been considered not effective, is high frequency to the right, Because you've got the melancholic artist hemisphere on the right side. Why would you want to excite that hemisphere? The thinking was, that doing that would result in more depression, or certainly no benefit. And what I'm going to tell you is that we are challenging that paradigm significantly with our study that I'm going to describe for you in a little bit. So let me talk about sort of where the field of TMS is with regards to optimization and how to get the most bang for our buck with predictive parameters, precision, and personalization. So these maneuvers exist on a spectrum of optimization, from generic to specific, working on sort of group level data versus working at with an individual's data. So predictive analysis is the using aggregated data to identify what are the features, what are the clinical features of this person that will allow them to have the best benefit, and how can we modify the treatment, or determine maybe they shouldn't receive treatment in order to kind of get the best efficacy rates, and also not waste someone's time if we know that it's going to be low likelihood of improvement. Parameter selection is something that we do, I've alluded to already, but we can do more because we have more parameters now that we're able to manipulate to try to maximize safety and efficacy. Precision targeting, this is the use of neuronavigation, or the use of tools that allow us to put the coil right on the spot that we want to hit in the brain, and to do that every single time consistently. Usually what we do right now, it does not involve neuronavigation with these special tools, and I'll share with you kind of what happens when we do that. And then finally, personalization. How can we use the specific characteristics of this person to inform our treatment? So not aggregated data, but their specific individual data. So we'll touch on each of these briefly and talk about how we're trying to do a lot of this in our study for late life depression. So factors associated with TMS efficacy, or actually more as is the case, lack of efficacy, age. If you're older, there are several studies that indicate that you may have less of a response to TMS than if you're younger. We don't understand why this may be, but certainly what we see is that as you get older, the brain's excitability tends to diminish, and also there's age-related atrophy in which the brain slowly is shrinking and moving away from the skull surface. So you may need more energy in order to just even to reach the brain in order to have an effect. And so we think that that may have something to do with it. There may also be neurodegenerative changes, and that is something that really has not been looked at yet. Treatment resistance affects whether how efficacious TMS can be for you. So if you are someone who has only tried a couple of antidepressants, you are more likely to have a TMS response than if you're someone who has already tried 10, 12, 15. So the level of treatment resistance. If you've tried ECT and failed ECT, that speaks to a very high level of treatment resistance, and that indicates that TMS is likely you're going to have a lower rate of response than if you haven't failed ECT. If you have melancholic features in your depression, and again, this is sort of an allusion to the title of my talk, if you have features in your depression that indicate that ECT is probably going to be most efficacious, such as psychotic depression or catatonic depression, melancholic depression with leaden paralysis, profound fatigue, these are features that indicate that TMS is less likely to be efficacious. I can tell you with certainty that the people who come into our service and say they have, really, really sort of bone deep fatigue that just nothing seems to touch, those people are much less likely to respond to TMS in our experience. If you have bipolar disorder, so bipolar depression, it was thought that this would respond to TMS as avidly as unipolar depression. However, a large study just came out this year that showed no effect of TMS for bipolar depression when delivered to the left dorsolateral prefrontal cortex. So that now is potentially an indicator that bipolar depression is different and may need some other technique to approach it. So Dr. Tone, you've always been recommending that we investigate this area, and I think there's definitely still a need for that to be done.
I'm sad, Dr. Quinn, I'm sad.
Well, it's more motivation for us to keep proceeding. Benzodiazepine use, if you're on a benzodiazepine and you get TMS, there seems to be a lower rate of response, as this study shows with the blue bars. If you're taking a benzo, you're the dark blue bar, your chance of responding and remitting is lower than if you're not on a benzo. However, if you're on a stimulant, that seems to actually improve your chances of responding and remitting, as a separate study showed. So very interesting sort of what's being learned about the clinical predictors of TMS efficacy. This study that came out in 2018 really kind of shook the field. This is the Drysdale paper, where they looked at a huge number of patients who had functional connectivity fMRI and then went on to receive TMS to the dorsomedial prefrontal cortex. And they saw that the connectivity patterns actually seemed to predict who was going to respond to TMS. So the people who were represented by the blue bar with the connectivity biotype 1 had a very robust response to TMS. 80% of them reached response. The people who had the purple connectivity pattern, the biotype 3, responded a little less avidly, but they still had a significant rate of response. But the people who had biotype 2 or 4 had very low rates of response to TMS. So this was sort of a groundbreaking paper that helped identify the possibility that we could look at functional connectivity and see that people have specific patterns associated with TMS responsivity. So we're all looking forward to the replication of this and Not sure that we've seen it yet, unless Chris has seen that, a paper that's done this. Let's move on from clinical predictors to parameters. So the field has accumulated a lot of wisdom over the past 20 years. We now have become more aggressive in how we deliver TMS. We initially were very concerned about safety. The main risk of TMS, although very rare, is that your brain gets so excited that it has a seizure. But that's only happened 20 times in the millions of treatments that have been delivered in the world. So we have been pushing the envelope in terms of TMS parameters and what we use. So it used to be that we would deliver only 10 to 20 hertz, but now we use theta burst, which is 50 hertz, as the frequency of stimulation. The intertrain interval, how long do you wait in between one set of pulses and another? It was thought that if you had them too close together, the brain would, the excitement would summate and you get closer to having a seizure. Turns out that we can put them almost 10 seconds within each other, and it's totally safe. No increased risk of seizures. That has the benefit of significantly reducing the time for delivery of TMS. The number of pulses per session, in this case, more is better. When you deliver more pulses, we started off at about 1,000 to 1,200 per session. Now we've moved up to 3,000, 4,000, 5,000 pulses per session. That seems to be associated with an increased chance of responding and remitting. I will say, though, that there is a Goldilocks aspect to this, in that some patients may respond only mildly at 3,000, respond more robustly at 4,000, but then when you go to 5,000, they actually start feeling worse. And so I think that there is definitely, we run into this phenomenon often where there's just the right amount of stimulation and you don't want to be under or over that for particular patients. The number of sessions that we give total to people, it used to be just 20 sessions, a session a day for 4 weeks. And now we are delivering 10 sessions a day, 5 days in a row, giving them 50 sessions. That's called an accelerated protocol. That's the most aggressive protocol that's been done, that's out there. I'll talk about that briefly, but we're now seeing that, we can deliver thousands and thousands of pulses a day safely. We can also use the maximum intensity of the magnetic field, up to 120% of the motor threshold. We haven't gone any higher than that. That's pretty much the field's ceiling in terms of how high you can go. And then positioning the coil, it looks like the more anterior lateral that you have it, the closer that you have it towards the eye, actually seems to improve the efficacy. Not necessarily because there's something we've been in the wrong area, but I think probably because we have been in the wrong area, and bringing it more anterior lateral actually brings us closer to the true DLPFC. This is the theta burst TMS study for depression, the 3D study that showed that by delivering theta burst, you can actually you can achieve the same results as you do with traditional 10 hertz stimulation. So as you can see with the graph on the right, there was absolutely no difference between the people getting theta burst and the people getting 10 hertz. The main difference in the protocol is that the 10 hertz protocol takes 40 minutes and the theta burst protocol takes 3 minutes, because it packs all those sort of pulses together much more closely. So it's very efficient. It's much more, it has much better patient satisfaction associated with it in terms of the time in the chair. This is the aggressive accelerated protocol that I told you about, the Stanford Saint trial. And what they did was they did 10 sessions a day separated by 50 minutes each. They determined that if you waited at least 30 to 50 minutes, that allows the brain time to reset. If you do it sooner than 30 minutes, you're going to run into canceling out the effects of the previous stimulation. And so the Saint protocol would do 10 hours of stimulation a day, and they achieved these results, which were just outstanding. It's an uncontrolled trial, but they still had, out of 20 patients, nearly everyone got into remission within 5 days. So they went from a MADRS score of 35 down to 5 in 1 week, which is just mind-blowing. And it kind of shook the field again. And it's caused everyone now to sort of see, how can we use an accelerated protocol? And that's actually what we're doing in our current study. So let me move to the precision targeting aspect of this and optimizing. And the field has made so much progress in this area. I mean, you would think that stimulating over the brain would be relatively straightforward. You just identify sort of where you want to go, but doing that in a non-invasive fashion and doing it consistently has been quite challenging. So it used to be that we would just measure on the scalp where we think the dorsolateral prefrontal cortex is with relation to the motor cortex. We would just find the motor cortex and go 5 centimeters in front of it. That proved to be a rather inefficacious method. We then started using Eeg coordinates. So Eeg coordinates are adjusted based on the circumference and the other measurements of the head. So they were a bit closer. They were able to reflect the changes or the differences in size of the head and head anatomy. And that has actually gotten us pretty close to the DLPFC consistently. Now we are starting to use MRI, structural MRI to identify this and use neuronavigation equipment to actually see where the DLPFC is and just put the coil right on top of it. And that's window C. Window D, E, and F are now using the functional activity of the brain to determine the target, not just the structure, not just looking at what is the structural DLPFC, but what is the functional DLPFC, and how can we put the coil right on that? Letter E is kind of where the field is right now. We've got a lot of data that shows that when you look at large groups of people and their imaging data, there's sort of a best average spot to put the coil. But F is really where we want to go, because I can tell you that I've put the coil on a lot of people's heads, and some people, they say it makes them feel better. And then the same spot on another person, they say they feel worse. And then they move the coil like 3 centimeters back, and that's the spot that makes them feel better. And that's nowhere near where the maps tell us to go. But something about this person, and about their brain is wanting sort of the stimulation at that spot. So how do we figure out where an individual brain, really will best respond to TMS? That's where the field is headed right now. So why did the scalp landmark methods not work? Well, because actually when we used the scalp landmark methods, we ended up putting the coil over premotor cortex, supplementary motor cortex, frontal eye fields, and only in the minority of instances did we actually get it into the DLPFC, which is this light gray area here. All these other areas had nothing to do with mood, but we were putting the coil over them more than half the time. So the early studies of TMS reflect this. The rates of response and remission were only like 15, 20% response. So we've abandoned these old scalp method for determining where to put the coil. This is what we're doing now in our lab. This is stereotactic neuronavigated TMS. So what you see is, we have the MRI on this computer right here. The patient is wearing a tracker, and there's a camera that you can't see that's monitoring the motion of their head. It's also monitoring the motion of the coil. And so it can actually sort of show the coil, as represented by this T here, is sitting right on the target in the DLPFC that we wanted to, as reflected by this green dot here. And so this is the technique that we're using in our lab to make sure that we always hit the target that we want to every single time. It's quite challenging. It's like playing a video game, but with this heavy magnetic coil. It takes a lot of hand-eye coordination and strength. So the people who get trained to do this, we really value their experience now, and we hope that they come back and keep working with us, because it takes quite a while to get comfortable with this. So now we're going to go to the personalization aspect of this, which is how do we figure out where is that perfect spot for this particular person to put the coil? And this is where the work of the past 20 years in looking at the circuitry of depression has really been useful. So the work of Mayberg, stretching back to 1997, has determined that the subgenual cingulate, which is this area kind of CG25 right here, down kind of close to the base of the frontal lobe, underneath the genu of the corpus callosum, that is a highly influential node in depression and antidepressant effect. And multiple studies, with drugs, with ECT, with psychotherapy, with deep brain stimulation, all show that the area called the subgenual cingulate, the activity there seems to change when you have an antidepressant response. It usually seems to, the activity seems to decrease. So we think that the subgenual cingulate is highly involved and highly important in depression maintenance. So how can we talk to that subgenual cingulate and get it to change? This is where the theory of networks, or the triple network theory, becomes very relevant. So we now talk about these three canonical networks in the frontal lobes: the default mode network, the salience network, and the executive network. They have functional connectivity within themselves and with each other. They perform different functions, or are responsible for different brain functions. And it's the functional connectivity of the executive network that seems particularly useful for talking to the subgenual cingulate. It seems to be highly anticorrelated with the subgenual cingulate. And it's the work of Michael Fox at the Martino Center at MGH, with my colleague Joanne Camperdon, that determined that the anticorrelation within the DLPFC with the subgenual cingulate was highly meaningful for targeting of TMS. So you can sort of see these tracings of the activity of the subgenual cingulate and the DLPFC, and you see that they go like this. They're anticorrelated. One goes up and the other goes down. One goes down, the other goes up. Multiple studies have shown this. Weigand's group has also shown this. And there's this spot that sort of emerges that is consistently anticorrelated across many, many people. And we think that this region, this sort of blue anticorrelated region, is where we really want to be putting the coil, in general, because that's where the DLPFC is anticorrelated with the subgenual cingulate. And Robin Cash in Australia is just putting out paper after paper showing that studies of TMS for depression are converging on this anticorrelated zone. So studies that showed high efficacy turned out that they had a target that was near this zone, and studies that had low efficacy were at targets that were far away from that zone. And that over time, the studies seem to be in their location converging on this anticorrelated zone. And the best sort of evidence of this yet, this came out earlier this year, which is that actually in patients where you get close to that zone, their antidepressant response was significantly improved. So the distance from that zone seemed to affect how much antidepressant response you got from TMS. So this is, amazing, amazing work. We're converging in on this. We're probably getting close to being done with the work on the left dorsolateral prefrontal cortex. And here are the imaging studies that show what happens to connectivity when you stimulate effectively. Connectivity is generally increased before TMS and decreases in the triple networks after effective TMS. And so this review, kind of looking at it this way, really suggests to me that depression is a disease of hyperconnectivity in these networks, and that by delivering effective TMS, you are ameliorating a hyperconnected state and disrupting it temporarily so that these canonical networks can function autonomously from each other. That's a bit hand wavy, what I just said right there, but the picture here from this review is really sort of what I turn to when I think about what is the effect of TMS that relates to antidepressant effect. Okay, I've blown through that pretty fast. I want to now sort of spend 6 or 7 minutes just talking about the cool stuff we're doing with our pilot study, using all these techniques for late life depression. Late life depression is a big problem. Our typical treatments don't work as well for depression once you get above, age 50, 55, 60. So we're very motivated to study this. Chris has been an incredible resource and guru for helping me to bring TMS to this population. So we're bringing in 18 to 26 subjects ages 50 to 79 who have major depressive disorder without psychosis. We're scanning them and doing cognitive and mood assessments at baseline. We then deliver accelerated TMS for about 15 sessions. We then repeat the assessments at midpoint. We deliver another 15 to 30 sessions, and then we finally end with a third scan and testing session. What we really hope to see is that, number one, that accelerated TMS for late life depression can be effective, unlike what some studies have shown earlier, and that we also can see that by neuronavigating to the specific targets suggested by the connectivity between the DLPFC and the subgenual cingulate, that we can get an even better response. This is just what our analytic pipeline looks like. So we're looking for levels of correlation and anti-correlation in the plots on the left. What you see are dark spots. Dark spots indicate anti-correlation. White spots indicate high correlation. And we're looking for sort of those dark spots. And one of the things that we noticed right off the bat was that, you know what, there's dark spots on both the left and the right, and they're symmetric. And so it made me think, you know, we think that we're supposed to do excitatory on the left, but inhibitory on the right. But here you have these anti-correlated spots that are symmetric. So do we really want to do inhibitory stimulation on the right side to the anti-correlated spot? And this is where I had a conversation with Chris. I was sitting in his office and he said, dude, why don't you just do the same frequency on left and right? You know, he just threw it out there. And I thought, you know, that would be a great idea. Why not? Why can't we just shoot for the same spot in the right hemisphere? Because clearly it's symmetric there. And so that's actually what we've done. This is sort of the final twist in our study that makes it, I think, really innovative, is that we're actually doing neuronavigated fMRI targeted stimulation to the right hemisphere, but with excitatory stimulation with intermittent theta burst, not with inhibitory stimulation. So we weren't quite sure what was going to happen when we started doing that. This is just, you know, how it looks when we bring patients in and we set them up, as you've seen. We're using their brain MRI and the targeting computer. We stereotactically determine their fiducial points on their head, and then the computer is able to keep track of their head and the coil and their MRI all at the same time. These are the targets that we've been able to acquire that tell us where to go. On our 15 patients to date, we have both left and right side targets, but we start with the right. And this is what we've seen so far. So this is group data, all the patients who've been in our study. And what you can sort of see here is that over the time of stimulation from session 1 to session 45, there's approximately a 7 to 8 point drop in their QIDS, which is a self-rated depression scale. And on the clinician administered IDS scale, there's a 50% drop, and this is over 9 days. So this is, you know, half of their depression is going away in under 2 weeks. And this is using excitatory to the right. So this is using a technique that everyone said doesn't work. And so we feel we're very excited about this because it's actually turning the field on its head, and it's really sort of showing that no, it's not that the left and the right are opposite. In fact, the left and the right are probably more similar than different, but we may need to understand what those remaining differences are. But this explains also why on our clinical TMS service, why a lot of people prefer right instead of left, because there's something, there is antidepressant potential here on the right that we had perhaps been ignoring because we just didn't want to do excitatory stimulation there. Anhedonia also improves. So on the SHAPS-C, which is a scale of anhedonia, there's a significant improvement over time. There's also a significant improvement in anxiety on the GAD-7 over time. So we're hitting anxiety, we're hitting anhedonia, we're hitting mood with right side excitatory stimulation. So this is really where we kind of brought it back to our clinic. We said, look, this is potentially viable. Let's treat some patients on our TMS service with this totally disruptive kind of paradigm. And we're the first 3 patients, you know, really responded to this. They had failed left side. And so rather than doing right inhibitory, we did right excitatory. And they got significantly better. Most of them got under 10 on their quids, and one even got as low as 5. So we really sort of think now that it's not about left, increasing the left and decreasing the right. It's really about how can we figure out which side is best to disrupt the connectivity state for this particular person in the same fashion. But it's really, we're trying to do the same thing on either side. We're trying to disrupt the hyperconnectivity of those canonical networks. Okay, so this is just sort of me kind of showing that, the right side of the hemisphere is the dark side of the moon as far as I'm concerned. It's totally unexplored. We know all about the left hemisphere. We know all about the side of the moon that faces the Earth, but the other side of the moon, we have no idea, the dark side of the moon. And so just one more musical reference, of course, the Pink Floyd album, Dark Side of the Moon, is one more musical inspiration for us to sort of keep doing what we're doing, because we think we're onto something here. And it's not really being done by any other group at this point. So just to end my talk, the take-home points: TMS is safe and effective. It may work by disrupting pathologic connectivity between networks. Using predictive factors, parameter selection, precision targeting, and personalization, we can improve the efficiency and efficacy of TMS. And this is what we're doing for late life depression at UNM. And these are the people that I have to thank. Our coordinators, CJ and Lindsay, our program manager, Kenya, our data analysts, without whom we would not be able to do any of the targeting that we're doing, Joel and Tom and Nick. Our core technicians who are paid on our grants, Marcus and Ben, who do yeoman's work there for our patients. And then all these volunteer technicians, Dr. Hager, Dr. McDonald, Dr. Hazelwood, and then medical students and even some undergrads, Justine, Olivia, Eric, Marco, and Sophie. I highly encourage you all to reach out to me if you'd like to join this team to help us keep doing this accelerated protocol. I would love to be able to offer this even after the grant money runs out. I think it's a great option for our patients. It's extremely popular with our patients. They really enjoy the idea of getting a bunch of sessions in each day. And so these are my collaborators on my various grants, but I'm happy to take questions from you guys. Thanks for your attention. Yeah, please tell me what you think, and I hope you want to get involved in our—
Let me make a comment, Dr. Quinn. First of all, congratulations for your presentation and for the work you're doing, and thank you for all your contributions to the department and putting together research with serving our patients. So you really, your leadership is a model to follow by all of us. Thank you, and you make us proud, Dr. Quinn. Let's open for questions. I think Dr. Arciniegas is ready there.
I am, Davin. This is fantastic work. Really exciting to see, and congratulations on helping to shift practice towards this more neuroanatomically informed approach. It's interesting. Fusar Poli in 2009 did a wonderful review and meta-analysis looking at the neuroanatomy of emotion as it's represented, as I'm sure you know, since you're nodding your head. I know you know this study. The outcome of the bottom line outcome message of the study was, yeah, the hemispheric asymmetry, left happy, right sad, just doesn't hold anatomically. It's bilateral. And there may be some subtle differences with approach avoidance and or anger, irritability, but it's still mostly bilateral. So I'm curious to hear your take and perspective on, a decade later, why are we still entrenched in the TMS world in this left-right dichotomy in the way that you have described it?
Gosh, well, thanks, Dave. I definitely think that we are trying to shift the paradigm. I don't know why it's so entrenched, other than it's a very seductive idea. The left-right asymmetry, it corresponds to how we think about ourselves, and as more left-brained versus right-brained. It has a lot of traction in the lay press, and kind of I mean, there are just a ton of studies that have shown that left excitatory and right inhibitory are effective, but very few studies to prove that wrong. And that's sort of what I think, the field needs, is we need more studies to kind of look at these outlier, so to speak, parameter sets, and actually confirm that they're outlier versus effective. So it was the effect of 2 or 3 very influential studies in the 90s and early 2000s that just got us on this course. So we're trying to backtrack, I think, and I think we are. I think the field is starting to reconsider those assumptions.
Fair enough. One follow up, if I may, on that. So this Price and Ochsner did a wonderful study. Ochsner and Gross have done another, looking at the anatomic activation, as you're talking about, with left, much like the Wisconsin card sort, left DLPFC being involved in generative and or more intensification of emotion, right homolog of that tending to be more modulatory, or if you will, anti-perseverative in relation to emotion. Do you see that playing out at all in the character, the phenotype of the depression in these patients, and particularly who does better with left versus who does better with right stimulation?
We were starting to feed certain patients to right and certain patients to left. The traditional classic sort of, anhedonic and, not sleeping well, low motivation, we are trying to use left. And the angry, irritable, anxious, more upregulated depression, agitated depression, we were trying to use with right. And now I'm starting to see cases, lots of cases where that doesn't hold anymore. And so those assumptions that we were using at first for our service are now, I can't rely on them as well anymore. So I totally acknowledge sort of, that the left and the right probably have different ways of handling emotion, or different, I don't know quite how to describe it at this point, but they seem to handle emotion differently, and the stimulation seems to create a different response. But I can't look at a person anymore now and accurately guess who's going to respond to left and right.
Other questions? Speak up or raise your hand.
Hi, Davin. Thank you so much for this presentation. It's really exciting work and tremendously well presented here. Really enjoyed it. I was curious, with any of the new fancy coils that can provide deeper stimulation, does anything approach that subgenual anti-correlated target that you referenced?
Man, that's a great question. And so that's what the deep TMS helmet folks would have you, sort of believe. Deep TMS with the H coil, the helmet, Brainsway is the company that sells that. Their efficacy rates are equal to the efficacy rates with the traditional coil. It gets deeper, but I do want to sort of point out that on a lot of those maps that I was showing, the anti-correlated area was quite close to a correlated area. And what it seems is that if you stimulate in the correlated area, you're not going to get a good antidepressant effect. You may actually get an unwanted effect. And so with the H coil, the area of stimulation, because you're going deeper, is broader. And I think there is the potential for stimulating more than just the anti-correlated areas that we would, that the research suggests you want to hit. So I'm someone who favors more focal stimulation, going right to that spot, and less broad. And so I will definitely acknowledge that the H coil, the deep TMS, works. And I think that it's just harder to understand where it's working because of the broader, deeper stimulation.
Let me ask you the last question, Dr. Quinn.
Sure.
And it's on right and left, and it's of course about bipolar depression. So of course you mentioned that depending on if it's the manic symptoms or the depressed symptoms, you do one or the other side. But as we know, the vast majority of bipolar patients have mixed symptoms.
Yes.
Up to 88%. So you've of course mentioned the failed study of predictors of not response. So the question is, was that done actually doing it on both, considering the mixed, characteristic of bipolar, or was it one or the other?
It was only done on the left side. There have been studies of bilateral TMS for bipolar depression. They generally followed the left excitatory, right inhibitory pattern. The initial early studies look to be quite effective. So I think that this one negative study does not diminish my enthusiasm or desire to treat bipolar depression with TMS. I think we're just still trying to sort out what are the best targets and the best parameters, and that's why we need to get a study funded doing neuronavigation for bipolar depression.
With that very positive comment, Dr. Quinn, time to end Grand Rounds on time. Thank you very much value your presentation. Thank you, Dr. Quinn.